what is the difference between psychiatric disorders and neurological disorders?
Neurological disorders affect uh, some part of the body, means it damages the brain. And in psychiatric disorders, there are different changes in mood, like severe depression, or there may be hallucinations, delusions.
Any other? Those who wish either can unmute themselves or put the answers in chat box. Okay, very easy to understand. Let me tell you. Those which affect psych, psych, which is related to mind,
Yes,
which is
sir.
related to behavior. Okay?
Yes, sir.
Anything which affects psych of the person, we'll call it as a psychiatric. And anyone which is affect the neurons in any way, we'll call them as a neurological diseases. Very easy comparatively to remember. So those who understand what is psych and neuron, then it becomes easy. Now, second thing, whether anybody has gone through the reasons behind these psychiatric diseases. What are the reasons why these psychiatric diseases they take place? Okay. Have you studied various drugs which are used in psychiatric diseases? In pharmacology, have you studied them? The drugs which are used in treatment of different psychiatric diseases. Okay, can you write? Can you update it? Please, those who wish can make it fast. Okay. Nobody has studied drugs in pharmacology. I think it was in your second year pharmacology. Drugs acting on CNS. Yes, anyone else? Antidepressants, antipsychotic, antiepileptics you studied in what, Pratima? In neurological or in psychiatric? Riddhi?
In neurological.
Fine. So, what those, yes, antipsychotic, very good. So now, those who are not answered earlier, from boys I want answers. What are the typicalness of antidepressant drugs? What typicalness you can say, or on the basis of mechanism of action of this antipsychotic drugs, what you would like to comment on? What were the basic mechanism of action? Boys this time. Boys are present. Milind, Ajay, Ashish, Saurav, Sagar, Shubham. Nobody can answer. Yes, Milind. Unmute.
Yes, sir.
So, what were the basic mechanisms?
They alter the dopamine interactions or dopamine release or block them.
They block the dopamine release. Very good. Ajay, Ashish, Saurabh. Yes, they do neurotransmitter. Everyone agree? Milind answer that they block the dopamine, isn't it? Very good. Can you name? Very good. Can you name some of the drugs or some of the mechanism? Even mechanism will do for depression. Huh? Hmm. Yes, can you please, anybody? Some of the mechanism, whatsoever classes you have studied for depression. So, can you name the either drug or basically, even if you say the drug, I'll ask you the mechanism. You can directly tell me mechanism based classification or any class of the drug. MAO inhibitors, very good. Very good. Any other? What MAO inhibitor should do? They will block dopamine which receptor? D1, D2, D3, D4, D5?
D2.
D2. MAO inhibitors will block D2 receptors. Very good. Any other drug? Dear friend, yes, Mansi said SSRI. What do you mean by SSR? SSRI, what do you mean by it? Selective serotonin reuptake. So, which receptor they will block? Very good. They will block 5-HT receptors. Anybody knows about reuptake? What reuptake is? Okay, I think we have had enough discussion on that. Yes, release transmitter is taken back by the neuron, and if it is blocked, if we say that you have got a reuptake inhibitor, then what will happen to the neurotransmitter? The concentration of neurotransmitter in synapse, what will happen? Increase. Then which receptor it should block? Then which receptor it should block? Because previously I asked which receptor it will block, somebody said that, or which neurotransmitter it will antagonize. It was informed like this or that. Presynaptic receptor. Very good. What presynaptic receptors are doing exactly? In what context they are important? Very good. So if the neurotransmitter concentration increase in synapse, what will happen to neurotransmitter release? It will increase or decrease? Suppose we are going again sequence wise as per your answers. You started that in depression they block certain receptor. Some of you answered it is dopamine receptor. Then we went for drugs, various drugs. The first one was MAO inhibitor. When I asked which receptor they block, the answer was D2 receptor. Then third one answer was SSRIs. My question was which receptor they block, it was 5-HT, isn't it? Then lastly when I ask how it blocks, then it comes as a presynaptic receptor. So usually presynaptic receptor, if they are blocked, what happens to them? Because it is agonist, it is not antagonist. and if it binds to presynaptic receptor, usually in most of the time what they are called as, what these presynaptic receptors are called as, is there any other name to this presynaptic receptor? Since it is doing regulation of release of neurotransmitter, what it is called as? Any name is given? Very good, they are called as autoreceptor. So if the agonist bind to this receptor, their own release will decrease. Okay friends, it seems that you are either you are not prepared at all or you are too much confused. But those who are interested, actually this is not part of therapeutics, but I just wanted to check that what I suggested to you to read the basic things, how much you have read. And I'm sorry to state that most of the answers were wrong, almost all I'll say. Okay, you'll realize once we go. But those who are interested, those who want to have a good knowledge about these topics, there are two very good sources are there. One is Psychopharmacology by Stephen Stahl, very good book it is, and that gives about various reasons behind the diseases, and second thing is various treatments. And one more thing is there, it was very famous in very few book it is there, that was called as a Stahl's theory, or it was called as a monoamine theory of psychiatric diseases. Those who want, they can search it on website somewhere. So what is a monoamine theory, what are the pros and cons of it? That will definitely add to your knowledge. Let us go for the topic of depression. If you have difficulty, if those who are interested and read it actually, those who want to, as I told you that those who are having clear basics will be able to understand it in better way. So those who want to read, those who read it and they find any difficulty, they are free to ask on our therapeutic groups. Okay. And if those who don't want to read, or those who want to have any additional knowledge, there is no problem, because anyway therapeutics is additional knowledge to what you have studied in pharmacology. So let us go ahead. So first one is depression. You must be knowing what depression is, what we will be studying, what are various what we will be studying in this, because as per our syllabus we should have diagnostic criteria. We should see what are the prevalences, consequences of depression, and various treatments which are there. So let us go for that. What is depression? Depression is as such, it is unrecognized and undertreated, because many patients, they do not understand, or even their relatives, they do not understand that person has got depression, and that is biggest problem. And those who read newspaper in India, particularly in Maharashtra, they may be knowing the suicidal tendencies, they are in increase. So there are many suicidal tendencies are there, and basically these are fallout of depression. Many who die by suicide, as I told you, they suffer with depression, and most visited physician within a month before a death. The untreated depression can delay recovery, or it can worsen the outcome, or other medical illnesses, and it increase the morbidity or mortality. Depression is not a part of normal aging. That is, if it is in adulthood, it doesn't mean that because of aging it has been there, because there are people who live beyond 90s and they are happy and agile. So then next we'll go for, that is what are the strategies, because a very important thing is there, those somewhere you have read Rangendale pharmacology. So in the beginning of CNS, I don't know whether I'm not remembering whether it is there is still there in new editions, but in I think 5th or 6th edition, I remember I have read it. that the knowledge about the central nervous system, at present whatever knowledge we have about CNS and the functioning of CNS, is something like passing a candy floss through a big cannon. Cannon, you know? Cannon, you know? In Marathi we call top. Okay? So very big gun is there, which was used in bigger this one, and particularly those who have visited here Daulatabad or something, here you might have seen very big kind of these guns. So it is passing a candy floss, a small, very small one, which is used for candy or like that. So passing like that. So it is so huge. Or crossing a big this one big crest between two hills or valleys, crossing big valleys using a very tight thread instead of rope. So this much knowledge at present we are having about CNS, because it is so huge, so complicated, and therefore many do not know. But still, in this example, for hypertension you can measure blood pressure. In GIT you can put a scope inside and you can check what is there. Now the problem with the psychiatric diseases is, even if somebody goes for x-rays, they may not able to understand, because it does not reveal big changes in oral anatomical one, because these are changes are there in what? Neurotransmitter release. So it is very difficult to diagnose, but then scientists, they have worked on it and they have devised a technique to assess and diagnose this condition. So we call, that was known as a diagnostic and statistical manual of mental disorders. So it started in 1952, that was called as a DSM-1, that is diagnostic and statistical manual, DSM, diagnostic and statistics manual, that was one. Then in 1968 2, in 1980 it was DSM-3, in 87 it was DSM-3 revised, in 1994 DSM-4, in 2000 it was DSM-4 text revision, and the latest one nowadays is a DSM-5. So these are the most important diagnostic tools. How they do? They are based on various questionnaires, and on the basis of these questionnaires it is tried that what kind of emotions the person are having. Because when we say psych, okay, we say psychiatric diseases, so in that case psychs or the mind related diseases or behavior related diseases, so they can come actually when you take the review of that, because as I told you, there is no direct diagnostic measure we can have, and in that cases this is the latest one, that is a DSM-5. There are some websites about DSM-5. It is official from American Psychiatric Association. They have given DSM-5 site, that is dsm5.org. And there is also present, it is on coping.us. These are some of the important websites which are giving some information about DSM-5. So what are DSM they have made? There are many actually. It is a very huge document, but we have made it. I have tried to make it only some important points I have taken. So DSM-5 is trying to be more etiological. Etiological means what is the basic reason? You know etiology. If you have studied pathology, then etiology means the basic cause. So what is the basic cause? And however, disorders are caused by complex interaction of multiple factors and various etiological factors. They can present within the same symptom pattern. So basically DSM-5 tries to locate the symptom, basic cause of symptom. Earlier were more symptom based, this is more etiological based. The diagnostic groups have been reshuffled, that there is a dimensional component to categorize the further research and covered sections 3 of the DSM-5, Earlier there was emphasis on developmental and adjustmental criteria. New disorders were considered and older disorders they were deleted. New emphasis was made for substance medications which are induced disorders and specific classification for them. They are listed for schizophrenia, bipolar, depressive, anxiety, OCDs, that is obsessive compulsive diseases, sleep-wake cycles, sexual dysfunctions, and neurocognitive disorders. So all these things which are been considered in DSM-5. So when we'll go for other topics like schizophrenia, bipolar, or any kind of diseases, in most of the diseases the basic diagnostic criteria remains same, DSM-5. Okay, this will be able to give on that basis, on the score the DSM will be giving what kind of problem the persons are having. Now let us go, as I told you, this is for various kind of diseases. So what is a mental disorders? There are many mental disorders, just now we have seen. So it is a syndrome which is characterized by clinically significant disturbances in an individual's cognition. I hope you know cognition. What is cognition? Yes, ability to learn and grasp, very good. Or ability to understand. So these are disturbances which are there in the individual's cognition, emotion regulations. Example, in some cases too much angry, in some cases not at all. Okay, so these are drastic variations in the emotions, or behavior that reflects dysfunction in the psychological, biological, or developmental process which is underlying mental functioning. This is means this all things, either psychological, biological, or developmental process, these are based on the mental functioning. Example, if there can be dwarfism, we cannot call it is mental functioning, because dwarfism may be related to growth hormone. Okay, so when we say that it is where the underlying cause is a mental functioning, developmental processes. Mental disorders are usually associated with significant distress or disability in social, occupational, and other important activities. An expectable or culturally approved response to a common stressor or loss, like death of a loved one, is not a mental disorder. But sometime if somebody if we see many times somebody dies, and either somebody some relative suicides for that, so then that means that it was a acute attack of depression. Okay, we call it as a depression after bereavement. Bereavement means because of the loss of or because of the death of some of the nearer relative. Okay, if those who have read it most in particularly South India, these are the very typical cases when some of the actors they die, many of their fans they commit suicide. So these are the depressions which are not otherwise focused, which were not otherwise found. That is because of the bereavement of some of the loved one. So these are there. Therefore, there is a variation in the sadness and the depression. We shall discuss it. So these are the common. Sadness is an expectable or culturally approved response. Somebody dies, people are sad. It is expected. Rather, it is socially approved. And if somebody doesn't show sadness or is not a sad person, then again people will think that he is having some problem. So sadness is okay. If somebody dies in very close relation, if somebody expresses happiness, then again it is some psychiatric disturbances. And if some commits suicide, then that is again another end or another pole of psychiatric disorder. So in between two, whatsoever sadness is there, that is normal. So it is not a mental disorder. Socially deviant behavior like political, religious or sexual, this may not be mental disorders. But if it going beyond it, then it becomes socially deviant. Means somebody likes this party, somebody like this party, they argue, and then they may even have a fight. But then when it becomes absurd into it, then it becomes a sort of mania. This is another kind of, or it is opposite to depression. Then and the conflicts, they are primarily between the individuals and society. They are not mental disorder unless the deviance or the conflict results from a dysfunction in the individual, okay, as we have described. So this is all detailed mental disorder is given, and whatsoever diseases just now we have seen, I'll repeat this. Example of these are schizophrenia, bipolar, depressive, anxiety, obsessive compulsive diseases, problems in the sleep-wake cycle, sexual dysfunction, which are related with the mental disorder. Sexual can be dysfunction may be because of other problems also, which are related to genitourinary system, and it can be because of the mental health also. So these are various kind of diseases which are coming under the mental disorders. Why identify mental disorder diagnosis? Why we should diagnose it? Because we should understand, we never understand from the normal one. There are many films, are there many, there are many people who are schizophrenic, they are working very normally, they are present in society, they are nearby. Same is the case with the person who are having depression, they are otherwise talking nicely, everything is nice. So why we need to diagnose? Because we understand that if this continues, it can progress, and if that progression goes beyond certain limits, then it can cause a loss to the society. So it helps, the diagnosis of mental disorder has got clinical utilities, like it helps to determine prognosis. I hope everybody understand word prognosis. That it helps in the development of the treatment plans. Once we understand what kind of disease it is and what can be the etiological factor is there. Mostly if you go for pharmacology, you might have seen that at many places etiological factors, they play very important role in deciding the drugs. So therefore our DSM-5 will help in giving you the etiological tools, and because of that etiology it will be comparatively more helpful, or more better to plan better treatment. It helps to give an indication of potential treatment outcomes. That diagnosis will help you to give the proper treatment plan. The diagnosis of mental disorder is not equivalent to need for a treatment. Need for the treatment is a complex clinical decision which is made after following points, that is symptom severity, how much severe symptom is there, then symptom salience, presence of relevant symptom like suicidal ideation, suicidal tendencies, etc. Client's distress, whether the client is going through mental pain. Example, if somebody feels that there is a acute this depression attack is there because of bereavement, so already the person, or because of the loss of job, because of the financial crisis, there can be anything. These are the distress, mental pain. These are the associated with the symptoms. Disability related to the patient's client symptom, risk, here client means patient, risk and benefits of available treatment, and other factors like mental symptoms which are complicating this illness. So these are various factors has to be considered, and accordingly the treatment has to plan. See how many criteria the DSM is provide. It is providing for the neurodevelopmental disorders. There are many neurodevelopmental disorders that patients or person grow in the age but not in the mental aptitude and all. Then schizophrenia spectrum and other psychotic diseases, bipolar and related disorders, depressive disorders, anxiety disorders, OCDs and related disorders, trauma, stressor related disorders, dissociative disorders, somatic symptom and related disorders, feeding and eating disorders. If somebody knows it is sort of depression, that was known as a bulimia. very famous personality, Princess Diana, had it. That was called as a bulimia. That sometimes they feel very hungry, sometimes they all of a sudden go on very heavy diet. Okay, so this kind of extreme mental fluctuation on feed habits they go on. Those who want can search on bulimia also. Then elimination disorders, sleep wake disorders, as I told you, sexual dysfunction, gender dysphorias, particularly female, some lowness is there many times, feeling lowness. So these are related to gender. During pregnancy, during menstrual period, and most of the time, rather in most of the female, it is there during menopausal period. So these are the gender dysphorias. Disruptive impulse control and conduct disorders, problem in the control on the impulsive thinking, impulsive behavior, substance related and addictive disorders. You must be aware about it. Various drugs nowadays, too many things are going in the news channels after Sushant Singh Rajput, drug and addicted substances. So related to that, neurocognitive disorders, personality disorders, paraphilic disorders, and many such disorders are there, which are basically characterized with these DSM diagnostic categories. As I told you, what they are a mix of various things. The DSM respect for age, gender, and culture. In each diagnostic definition, appropriate things are incorporated, like developmental symptom manifestation regarding the age of the client, because age wise the person's behavior should get modified. At younger age, maybe some aggression, at somewhere elder age, more mature decisions like that. Gender specific disorders, as I told you, females and male can have a different set of psych or mindsets. Cultural sensitivity in regards to certain behaviors. So these things are incorporated. Now what is depression? As we are going for that, and this was we have seen that earlier also, we'll repeat it. When DSM 4 was there, before DSM 5, so what it was defined: 5 or more of the following must have been present during the same 2-week interval. Okay, for 2-week interval is there, means test is taken today, and again next week the test is taken, and they represent the change from the baseline functioning. One of the symptoms must be depressed mood or loss of interest or loss of pleasure. So what are these? These are, it shows a core symptoms that occur most of the day or nearly every day. So even the patient or the nearby people, they can say, or they can inform about this. What are these depressed mood? You can see the picture over here, like that. That is, body is drooped here. So this is so this drooping, you can see like this, the body is drooped, feeling that lowness, depression in the mood. This is it doesn't mean that body show this kind of stature. It indicates the lowness of the person, that is depression. Okay, the shoulders and the neck and everything, it reflects. It doesn't mean exactly the person will appear like this, but this lowness of the person has been indicated in the figure. The loss of interest in all or almost all activities, particularly including the pleasure, anything which is otherwise pleasurable. Somebody are having good food habits, they are happy with the food, some are happy with the music, some may be happy with the movies. Okay, so what kind of the things which are there for their own pleasure, so this is also they lose interest in that. There is no interest in whatsoever activities they are supposed to be for pleasure. So this is called as anhedonia, that is loss of this sense of pleasure or loss of happiness in that. There may be appetite change or weight loss. Appetite change word is used, as I told you. That is, as I told you, sometime much eating, sometime all of a sudden no eating, like that, and result into weight loss. Insomnia or hypersomnia, either sleeplessness or more sleepiness. Psychomotor agitation or retardation. So it can be agitation, but again it is not as it is there in mania. Retardation means no reflex for psychomotor activities. Loss of energy or fatigue, or it is a fatigue like situation. Feelings of worthlessness or excessive guilt, like example, somebody is getting it, as such it is getting. So this is a cycle. What happens is they lost interest, therefore cannot perform. They lost interest on all the things where it can be happiness. So they do not want to involve in any activity, they do not mix up, and they even do not perform well in the work. So that may lead to their problems, maybe loss of job or educational losses if they are studying, or whatsoever stage they may be having of life. If they are early student life, then problems in the study and performance. If the job one, then performance in the job. Then because of that, the performance indicators will not be clear one. If performance indicators are not clear, then failures will be there. Maybe failed in examination, maybe kicked from the job, or not. If not kicked, then at least promotion etc. will not be there, or financial help will not be there. Because of that, they start feeling worthlessness. Because of that, that is, they are not of any worth, they are useless. That feeling goes. That feeling still increases the depression more. They may feel again guilty. I cannot do what I should have done. Okay. Maybe if student, he will say that no, my parents has so many expectation, hopes on me, and I cannot do. I am not able to perform. I am not doing it as it should have been done. So again, this excessive guilt will be there. That excessive guilt will also cause damage to the neurotransmitters and that neurons, their release. Difficulty with thinking, concentration, decision making will be problem. Recurrent thoughts of death and suicides can come. Preoccupation with somatic symptoms like health status, physical limitations will be there. Even means although the person is physically fit, but still will feel that will not able to do the physical activities, maybe running, walking etc., because it is preoccupation in mind that I am not able to do like this. So there are variety of types. We shall be seeing this. The most dangerous or most important is a major depression. It produces social impairment. That person gets detached from society, will not able to have any touch with the society. They are not related to substance abuse, because those who are having substance abuse can also have such kind of symptoms, but here without substance abuse they will show. They are not related to bereavement, means nothing has happened to their life otherwise. They are not taking any drugs, nobody has died, even no big concern has been there, maybe financial. Still they feel that they are worthless, and this they are of no use. They may feel guilty for any reason without any such cause. So this is what depression is. Now what are the various types? We shall see again another type. Some of these are mild episodes of the major depression, moderate episodes of major depression, severe episodes of major depression. So whenever there are severe episodes of major depression, many times it is very difficult to stop the person from suicide, because even somebody stops him today, tomorrow by any way he will try to succeed in that. Severe episodes with the psychotic features shows the signs of some psychotic behavior, means absurd behavior, psychotic here you will call it as a. So there may be this major depression with the psychotic features will be there. Minor depression is that way common. It happens in 15% of older person, and in many people it is there. It causes increased use of health services, excess disabilities, poor health outcomes, and increase in the mortality, because either death will increase, or if particularly elder age it is there, they may not take whatever their routine treatment is there. If maybe they are on the antihypertensive treatment or any cardiovascular or other problem treatment is there, they may not take it, and that can also result into mortality. So therefore in depression, mortalities can be because of two reasons: either suicidal attempts or not taking enough care of their own body because of the loss in interest. Major depression is not that common. It occurs in 1 to 2%. Overall, elders are less likely to recognize or endorse the depressed mood because they may not understand it, and therefore it has to be verified. So in particular geriatrics, in the adult one, late life depression is a recurrent of a depressive symptoms that initially occurred during early adulthood. There is no known or identifiable precipitating factors, just like we have seen bereavement is there, loss of job is there, financial problem are there, some stressful situations are there. Patients usually have no family history of depressions. Depressed mood is not required to meet criteria for major depressive disorders. So what are different type of depression? As I told you, the major one we have seen, it is a major depression. It is a classic type of depression, and it is actually diagnosed or labeled as a MDD. Okay, major depressive depression. It is also known as a unipolar depression, because if you know, we have seen or we know there are diseases, we call them as a bipolar diseases. When there is a lowness of the behavioral activities, we call them as a depression. When there is high in the activities, in unipolar one, we call them as a mania. Depression and mania are that way we can say opposite to each other. Depression, mania is it may cause or it may affect the not only person but even the nearbys, because they becomes aggressive. Here the person is not aggressive in depression. People with major depression have symptoms of depression most of the day, nearly every day, and the episodes of last 2 weeks can experience recurrent episodes throughout their lives. It can further break down depression into several specific subtypes of this major depression, like seasonal affective disorders. It emerges during particular seasons of the year. Commonly they are more during winter. It is brought on from the diminished natural sunlight. Now people will realize how sunlight is important in the life, because when there is a decrease in the sunlight, the chances of depression can increase. Then atypical depression, it is the biggest differentiated is the mood reactivity. People with this kind of depression see their mood improve when something positive happens, but it is transient, it is not lasting long. Then bipolar disorder, here both poles are there. It is also called as a manic depression earlier. So mania will also be there and depression will also be there. It involves alternating between episodes of depression and extremely elevated energy, or we call it as a mania. Okay. So sometime all of a sudden we'll talk too much, we'll talk absurd, it can be aggressive, this is mania, and all of a sudden there will be lowness, no talking, feeling uselessness. This is what bipolar. Then psychotic depression, when person experience depressive episode so severe that they start having false fixed beliefs, delusions, like in schizophrenia, or hearing or seeing the things that others cannot see, we call it as hallucinations. This is along with depression, schizophrenia, this kind of depression exists. Postpartum depression in females, particularly after giving birth, mother may feel that the baby get hurt with them, and therefore they get away from the baby. Those who might have read the recent news, I think if you search the Lokmat newspaper, most probably 8 to 15 days before only, one lady was found, she was having psychiatric disease, and she was trying to dip her baby into pond, um, and she was not even allowing anybody to touch the baby. And some of the social activists, they then took that baby, and it was, she was doing out of love for the baby, but fortunately baby did not get hurt. So these are such kind of situations are there. They feel that they are trying to protect, but then they will go away. They may not even feed the baby. They will feel that they are hurting the child because of one or reason, and then it may hurt actually the child. The premenstrual dysphoric disorder, it is a severe type of depression that shows up during second half of the menstrual cycle. Situational depression, that is adjustment depressions, these are due to depressions that is triggered by a significant life changing event. Example, as we have seen, bereavement, that is somebody very nearby was there, somebody close was there, died, or all of a sudden, example, COVID like situation, all financial or collapse is there. You might have read, or there may be some families, all of a sudden their business has got a problem. Somebody from their family, maybe very closer one, two, three, four member whatsoever there, they caught COVID, get died, and this type of simultaneously 2-3 attacks can be there. They are enough to make the person depressed. So these are the situational depressions. So many like that, in particularly at younger age or in the adolescent age, the that is getting away, or what we call it, what you people call it as a breakups between girlfriend, boyfriends. These are various kind of situational depressions which are there. Then persisting depressive disorders are there. Earlier it was called as a dysthymia. It is a chronic form of depression. It is usually with a mild symptoms, and there are episodes lingers for a long period of time, sometimes 2 years or more. It could be described as a feeling like you are living on autopilot. That means life is going as it is without doing anything. In autopilot mode of car, people, they are not driving, they are just sitting, and automatically car is being driven. So this is like that. This persistent depression is there. So epidemiology, as I told you, it is around 1 to 9% people are having. Out of this 1.5%, 9% around, because major is total are 1.9%. In that, some of these are hospitalized, around 11 to 45%, up to some are having permanent placements in the nursing home, and primary care settings can help in around 10 to 12%. So it will depend person to person. Why there are depressions? What are the reasons? What are the etiological factors? We have seen that DSM ask for the etiological factors for depression. What are these? So there is no such single cause so far has been found. But there, as I told you, you can refer a very good book, that is Stephen Stahl, Psychopharmacology is very good book. So there can be many reasons behind it, and many a times actually it is more than one reason which is doing it. So there are many factors are there, genetic factors are there, environmental factors are there, then whatsoever family factors are there, how the person has got upbringing. So these all factors will be involved into that. Examples of these are, what are various factors are, brain's physical structure or chemistry. In some people with depression, brains can indicate a smaller hippocampus, which plays a role in the long-term memory. Research shows that ongoing exposure to stress can impair the growth of nerve cell in this part of the brain. So hippocampus can be smaller than the normal people. Serotonin levels are out of balance, particularly the brain may be connected. Serotonin receptors act differently in someone without depression, and therefore the serotonin is important treatment. Then because as I told you, genetic reason is history of depression in the family. So someone with the parent or sibling with the major depressive disorders has 2 or 3 times greater risk of developing depression than averaging person. Genetic code is different. So last year, I hope you have paid attention to that. When we studied various genetic things, and we have seen that any change in genetic situation can lead to any kind of disorder. So similarly, here it can be there. There are from parents the genes are there. These are called as alleles, and when one or more short one is linked, having more of the proclivity towards depression, so then the depression one can have. History of other disorders or concurrent mental health conditions, example post-traumatic stress. Trauma can be physical or stress. As I told you, somebody died in the family is also traumatic, or somebody met to an accident can also a trauma. So it can be any kind of traumatic stress. So after trauma, so it can be physical trauma or mental trauma. Okay. So the substances use disorders, then learning disabilities are commonly associated with this, and it can precipitate depression. Anxiety is also one of the major cause. Means if the anxiety remains untreated for a long time, it can result into depression. Up to 50% of the people who have depression also have anxiety disorder. Stressful major life events, so it can be abuse, financial issues, death of loved one, loss of a job. There are many such jobs which can trigger depression. Now the thing is, and there can be many positive events are there, like good move, getting married, graduating, retiring can make somebody feel depressed too. For these events, their routine should be altered, but they can also trigger feeling that whatever the success, happy occasion, it is not deserved. In some cases, because of hormonal changes, just now I told you, menstrual cycle, pregnancy and giving birth can cause bouts of depression. Certain physical conditions like chronic pain, headache show correlation. You might have heard that people end their life because of maybe that way curable, but time taking, like arthritis, which is not making big impact on the otherwise it is not a cancer like disease where the person is certainly going to die, but then because of such kind of diseases there are depression. Certain medications we shall see them, like blood pressure medications and many other CNS acting drugs can cause depressions. So there are many such reasons which are resulting into depression. So as we have seen earlier, one should go for finding the cause, and then one can go for depression. I think we'll stop. I'll just complete few risk factors. So there are risk factors like alcohol or substance abuse, any medications which are causing depression and it is being used for long term, hearing or vision impairment, which is severe enough to affect the function, because hearing, vision, they are many times objects of pleasure. Hearing, people like to or love to hear from their loving ones, and music, etc. Everything, hearing, helping. Same is the case with the vision. And if it is affecting the function, then that can add into depression. History of attempted suicide, history of psychiatric hospitalization, medical diagnosis or diagnosis associated with a high risk of depression, new admission or change of the environment, stressful losses like loss of autonomy, privacy, functional status, and any such things, personal or family history of depression or mood disorders. These are the major risk factors. Okay. Now we shall see about what are the drugs and how it will be treated, what should be there. So now as a homework, please go through various depression, their scales, and accordingly what treatment will be preferring. Treatment wise, pharmacological classes, we shall see only what are preferred, what are not, why. So go through it. If you have any difficulties, in the meanwhile you can put on group. Take care and stay healthy.